Good morning, everyone. We are a bit behind the schedule, so I'd like to start the section without interruption.
I'm Dr. Tateshi from the University of Tokyo. It's my great pleasure to introduce our distinguished speaker.
Our distinguished speaker for this keynote lecture, Professor Grace H. Wong from Hong Kong, China. She is currently a professor at the Department of Medicine and Therapeutics at the Chinese University of Hong Kong. She is an outstanding researcher in this field of hepatology and received a lot of important awards. Please refer to the CV book of the speakers for detailed information about her career. She will give us a lecture entitled Strategy for Preventing NASH-Derived HCC. Unfortunately, we are informed that she has a difficulty in giving a live lecture. Instead, we have received a video clip. So please start the video clip.
Hello everyone, this is Grace Wong from the Chinese University of Hong Kong. I'm very pleased to share with you this important topic, the strategy for preventing NASH-derived HCC. Some of my personal introduction and disclosure. I'm particularly interested in the research of using big data, AI, machine learning, and HCC risk reduction prevention is in fact one of my key interests. Some of my disclosure of conflict of interest. MAFO, metabolic associated fatty liver disease, is a very important disease, progressive over the years, especially under metabolic drive. And disease will progress from NASH, as non-alcoholic steatosis, to fibrosis, cirrhosis, and cancer, which is life-threatening. And we wish to prevent all these nasty complications by stopping the disease activities, as well as to reverse the injury. And it progressed over the years to HCC. It will involve a lot of important risk factors of metabolic syndromes like insulin resistance, obesity, gluten intolerance, hypertension, dyslipidemia. So when we talk about how to prevent it, all these metabolic risk factors are indeed our key targets to control and to improve. As an overview, HCC attribute to MAFO or NASH worldwide will vary quite a lot. In fact, Asia is catching up. In the past, we believe that it's a small proportion, like less than 10%. But in recent years, we can see quite many of the regions in Asia Pacific regions have the incidence or proportion of HCC attributable to MAFO and NASH for more than 10 or even 20% of the cases. In Hong Kong, in fact, we are also seeing more and more such cases, roughly around 20%. And if we do this age standardized incidence rates of liver cancer, again, you will appreciate that. In fact, the rate is quite an important disease burden, especially in our region. Many large countries have many case burdens. So it's a very important disease area we should target for. And over the years, we can see the very dramatic change in the trend of having the course of HCC in liver transplant candidates. So like the purple lines here, in fact, is catching up very dramatically, especially the HCC prevalence rates kind of triple or quadruple up over the last 2 decades. And we look into more details based on different studies. Some will focus on MAFOD, some will be more focused on NASH-related cirrhosis. In fact, the incidence rate will vary from roughly around 0.02 to 0.9 per 100 years in MAFOD cases, because you know that quite many of these patients have simple steatosis or only mild fibrosis. But if we focus on the disease that with more advanced problem like NASH-related cirrhosis, the incidence can be as high as 6.7 per 100 years. So you may argue that, in fact, this risk level is even higher than patients have cirrhosis related to other chronic liver disease. So MAFOD-related HCC in Asia is a key problem. So like these few key studies in our region showing that it will occur in range from 0.25% over 5 to 6 years or 0.65% over 4 years. So are we not seeing many MEFO-related cases? So I think one issue is that quite many of the time we may not be 100% sure whether the patient have MEFO-D or not, because they already at the stage of cirrhosis, so we label them as cryptogenic cirrhosis. And also we need longer follow-up to observe and relatively late disease onset. It is not rising recently in the Western countries. So this very decent, elegant study in Japan showing a large cohort of Japanese patients with HCC more than 7,000, and with very detailed trend analysis over the last 2 to 3 decades, showing that the non-B, non-C HCC has been rising dramatically, with more than like 2 to 3-fold increase over the last 25 years, which signify, in fact, a very important increasing incidence of NASH-related HCC. Neighbor country like Korea also showing very similar observation. Like here, these are gray part of this pie chart showing that again, it enlarged quite dramatically from early 2000s to like more recent days. So again, showing that many of these patients are likely suffering from MEFO-D or NASH. This is a Western cohort from the veterans. So again, they analyze different risk factors. So here they show that in fact MEFO-D is one of the most important independent risk factors, like the adjusted hazard ratio would be as high as 7.6, even much higher than other well-known risk factors like age, BMI, and diabetes. And in our group, we also would like to understand the interaction between MEFO-D as well as patients with past HBV infections, because chronic HBV is still prevalent in our region, and quite many of our patients have past infections signified by the positive anti-HB core antibody, but negative HBV surface antigen. So here we find that if the patient have two conditions coexist, which means that the patient on one hand have MEFO-D, on the other hand also past HBV, as represented by the red line here. In fact, the incidence rates of liver-related event would be much higher in 10 years down the line. As well, you will see that from this bar chart, they also show that those with past HBV again have higher proportion of patients with more active disease and more fibrosis. This is another very detailed analysis, again, look into whether NAFLD with or without cirrhosis is one of the important factors. In here, they talk about whether we should screen for HCC. This is, I would say, that is still a bit controversial. In any case, based on a threshold of annual incidence of 1.5%, at this moment, only MEFO-D cirrhosis will be someone that we recommend for screening. But here, if you see a lower parts of this slide, in fact, those without cirrhosis, because the incidence is still relatively low, so there's no strong evidence showing that we should screen for them. But I would say that more data are evolving, because NAFLD or MEFO-D without cirrhosis represent a very huge cohort of patients, even though the absolute incidence is low, but the numbers of patients may still be considerable. Okay, so here it is the current guidelines or some key international bodies recommending HCC surveillance is not for all MEFO-D patients, but focus the resources for those with NASH-related cirrhosis. But I think, again, I would like to highlight that cirrhosis is not everything. So because quite many of the patients, they may have either mild, moderate, or advanced fibrosis, which in fact can be contributing to another significant part of the HCC among MEFO-D patients. So like here, especially the men patient, you can see that 61% of the HCC will occur in the setting that they do not have cirrhosis, but only from F1 to 3 fibrosis. So which means that if we really only screen those with MEFO-D cirrhosis, we'll miss these 61 male patients, another 30% of the female patient, overall roughly half of all the MEFO-D related HCC. That's another important issue we need to talk about. So like here in the VA, they also highlight that in fact, quite a significant proportion of the patients are like in MEFO-D or idiopathic, which I think they overlap quite a lot. 1/3 of the case, they have HCC, but they do not have cirrhosis. This again highlight that if we skip the surveillance, HCC surveillance for these patients, we'll miss this significant proportion of HCC. Here, this is our dilemma at this moment. If we focus on the strategy 1, HCC surveillance for only NASH-related cirrhosis, then we will use less resources, but we are prepared to miss at least 30% or even more of the NASH-related HCC. But on the other hand, we may consider strategy 2, HCC surveillance for all MAFOD patients, which in fact means that there are huge resources implication that we have to screen like 20 to 40% of our whole adult population, which is in fact a very huge healthcare burden. Okay, now I would say that probably we may think a bit more about what would be the key risk factors apart from cirrhosis. I think one thing is type 2 diabetes. Here in our population screening cohort, or patients with type 2 diabetes. In fact, we find that this is a very nice cohort to screen for MAFOD with advanced fibrosis, because the number needed to screen is only 1.4 to find one MAFO patients, and only 5 to 6 patients to identify one advanced fibrosis. And we know that advanced fibrosis would be one of the key risk factors of HCC. So I think there's some thing that we should actively screen for MAFOD advanced fibrosis, and then these patients should be undergo HCC surveillance. And other factors associated with MAFOD-related HCC in Japan would include advanced age, high liver enzymes, low platelet, which signify portal hypertension, and type 2 diabetes. And here they talk about, is there any risk score we may use? Some risk score are designed and derived and validated for either MAFOD-related HCC or alcohol-related HCC. So it's a very huge size cohort, more than 7,000 patients with MAFOD and another 16,000 patients with alcohol-related liver disease. And they identify some key risk factors which are very sensible, because all these are quite well-known risk factors for HCC, like age, male gender, BMI, diabetes, low platelet, low albumin, signifies cirrhosis, and also high kind of like AST-ALT ratio. Okay, so here again, you will see that 3 very nice levels of risk have been derived, and up to 5 years, the accuracy, in fact, is very good. The observed risk and predicted risk go hand in hand, with an area under the RC code, the accuracy close to 75%, which is something quite decent. And it would be quite a nice risk score we may consider to use in patients with MAFOD or NAFOD in our community or clinic setting. And then there would be some simple fibrosis score like FIB-4 score, which have been using it to predict advanced fibrosis in different kinds of chronic liver diseases. And here they find that it can be another kind of supplement of clinical diagnosis of cirrhosis, because sometimes cirrhosis may not be something readily identified from our basic like blood tests or ultrasound. So here, in fact, even those without cirrhosis diagnosis, but with high FIB-4, in fact, we can also see that the incidence rate of HCC is still quite substantial. But obviously, those with cirrhosis then already very high risk of HCC. And prognostic value or liver stiffness measurements have been well established. Like here, if it's a collaborative work together with a center from France and from our team in Hong Kong, we combined with more than 2,000 MAFOD patients and we prospectively followed them for more than 6 years. In fact, low liver stiffness measurement, less than 12 kilopascal, is a very nice cutoff, have a very high negative predictive value to identify patients with low liver-related events. So it is something that anyone with liver stiffness less than 12 is quite reassuring. Okay, now we know who we should screen for, but how? What would be the screening tool? We can use something that existingly available, transabdominal ultrasound, but we have to bear in mind that because the liver is very fatty, the person may be very fat, a lot of subcutaneous fat, we will have bear in mind the limitation of poor visualization, especially the deeper part of the liver parenchyma or some hidden area. And alpha-fetoprotein, limited data, and we all know that alpha-fetoprotein has only limited sensitivity and specificity, and even less sensitive in MAFOD-related HCC. How about other markers like this DCP or another PIVKA2? Again, is limited, may be less sensitive, but not sure. In fact, recently I come across some data showing that it may be a good supplement to alpha-fetoprotein to identify patients with coexisting MAFOD as well as chronic viral hepatitis-related HCC. Okay, we may use something more sensitive like this non-enhanced MRI, has a very high role of very high sensitivity, much higher than ultrasound, 79% compared to only less than 30%. Specifically, again, very high PPV and NPV. But I would believe that it is the availability is an issue, because whether your center do have MR machine available to do surveillance is another thing. But because it's non-enhanced, so there's no risk of having like contrast allergy or contrast-related nephropathy. Okay, so we also would like to understand the clinical characteristics of methylphenidate HCC. Like here, the survival of patients, HCC patient undergoes curative treatment is usually not as good. But you may say that compared to HCV patients, you may say the first 1 to 2 years will be comparable, and then later on, in fact, their survival would be quite stable. And here they compare the different characteristics. In fact, one thing that we have to bear in mind is that those with methylphenidate HCC, it tends to be a little bit more advanced, like here, a little bit more of BCLC stage 3. And again, you can see that many of the patients have relatively normal alpha-V protein. So in fact, the mean alpha-V is only 7.1 here, which is in fact just around the normal cutoff. And again, it highlights, as I mentioned, ultrasound has limited accuracy visualization. So that's why, in fact, methylphenidate HCC was less often detected in surveillance. So here, again, they show that, in fact, the surveillance received by etiology showing the methylphenidate HCC have relatively high proportion with no screening or inconsistent screening. And from this another served Medicare database, a large cohort of patients with HCC, again, they find that many of the methylphenidate patients, as in the orange bar, showing that less than 20% of them may undergo curative treatment, which means that, again, they were identified at quite a late stage. So this would be the treatment options, but something specific to methylphenidate HCC would be the outcome may be very comparable with HCV-related HCC as shown before, but there would be some issue about comorbidity like other metabolic problem, cardiovascular disease, cerebrovascular disease. That's the problem. And for liver transplant, there would be, again, similar outcome as HCV, but morbid obesity would be the issue we need to think about, a cardiovascular event. And for local ability therapy, not specifically tested for methylphenidate HCC, but you may imagine that patients with very obese condition, there may be technical difficulties. And also because many of the time HCC was diagnosed at more advanced stage, so there would be more advanced, there would be difficult to receive curative treatment like resection, transplant, and so on. So, and also at the same time, many of these patients may have chronic kidney disease. They may have been at high risk of having acute kidney injury due to TACE. Here, there will be some special situation related to the conditions in Asia. So I think our patients are different, tumor factors are different, and treatment factor may be different. So I think our treatment options may be slightly different from the West. Okay, so recently we have been using a lot of immunotherapy to treat HCC. How about the efficacy in methylphenidate HCC? There is some early data saying that possibly immunotherapy may not work as well in methylphenidate patients. Like from a Kaplan-Meier curve, you can see that the blue lines showing methylphenidate HCC, in fact, the survival usually will be shorter than other etiologies. But I have to say that this is still early data. We need more data to support. There may be issue about the metabolic things and the immune response and so on. So strategy to prevent NASH HCC, I think we should always try to diagnose early because it's something that's getting more and more common. So surveillance is important. At this moment, we focus our resources to screen patients with cirrhosis or advanced fibrosis. But how about those with only mild, like F1, F2 fibrosis? We need more risk score to help us, and at least to identify some patients are at a bit higher risk, then we should screen for them, like diabetes, advanced age, and treatment outcome for methylphenidate HCC in general is as good as other courses of HCC, but immunotherapy is something that we need more data to support. So with that, I thank you very much for attention. I would love to take any questions towards the end. Thank you.
Thank you, Grace, for your comprehensive and very informative lecture. Now she is connected to, she is online, so we have received 1 or 2 questions from the audience. Do you have any questions? So thank you, Grace. I'm Tateishi from University of Tokyo. And there are several promising drugs for the treatment of NAFLD today. For example, thyroid specific agonist showed a promising result in Western countries. Do you think that these drugs are available also in Asian countries?
Right. Yeah. Thank you for your important questions. Yeah, I think you named one of the most promising new drugs that for patients with MAFLD, which I would believe that it would be registered very soon. And usually, Asia may have this new treatment options slightly, maybe a few months or 1 year behind. But I'm quite confident that all these new treatment options would be very helpful to regress the inflammation, fibrosis, and then hence in the future can also reduce the risk of HCC. Yeah, thank you.
Thank you. Any comments or questions from the audience? So, so I'd like to close this session. Thank you again.
Thank you.
For your informative lecture.
Thank you so much.
Thank you very much.
Thank you very much, Chair and Lecturer.